Ready? Okay. Welcome. Good evening. It's a pleasure to have you. I'd like to welcome you in name of Nutricia. I want to welcome you of our global organization, of our local organization. And I think we have today a very special group. Actually, if you think about it, it's almost a global event. So I like really personally to welcome you and appreciate your time and the effort that you have coming here. And if we go from a little bit where the sun goes up, yeah, from Asia into Europe, into Latin America, we have in total 18 countries here. Enormous. So I would like to welcome the Indonesia team I have seen there. So very, very warm welcome to Indonesia. Then we have obviously a lot of people from Europe, so from Denmark, from Finland, from Norway, from Sweden, from Estonia, from Latvia, from Litauen, from my home country Germany, Austria, Netherlands, Poland, and UK, and also from Slovakia, Slovenia, and Czech Republic. So wow. And then a very warm welcome to my friends, which I very much love. You know that in Buenos Aires, from to Argentina, but also to Ecuador. Welcome. So I'd like to be brief, but at least this is an impressive location. Please go with me. So this is an old palais from a king. So around 19, that was bought by the real people who have the real money. That's the craftsman. So here and the back, there's all the seals from the craftsman, and you see here. This is the ones who are building the houses, then the wood makers, the car makers, the iron makers. So all the makers, and then the one who really owns the money. Um, and so they bought it and they restored it in, I learned in here, around 9020, 9030. So they built a whole new seal and they made this. And this picture gallery is actually quite famous in Copenhagen. So you should walk around and from Europe, from Venedig and so on. So a really nice place. But why I'm saying that is these guys have all worked on innovation. And innovation is not new. It is new at a certain time point, but innovation is to last. It's only good when it stays. And that is actually our topic for the day. We have the topic around biotics. We have the topic around prebiotics, which we find in human milk, probiotics, which we have never thought they will be in human milk as live bacteria. We always thought it is sterile human milk. And we have now most recently symbiotics, the combination, the lunchbox for the good bacteria, and postbiotics, they are metabolites. So a very nice presentation and overview, which we expect will be fantastic from Hanya. I will introduce you in a minute. And then we will go a little bit deeper in the clinical relevance of that for cosmic allergy. What does it mean for the daily practice? Because these men, they have not worked for the books. They have worked for their daily practice. So my colleague Rebecca Stratton will go really in deep on the use and evidence for probiotics and symbiotics in the dietary management of allergy. I just want to disclose also, I think you would have expected that I'm a full-time employee of Nutricia, just to be clear. So what do you expect today? First of all, evidence, data. Yeah. Quite late in the evening, we had all along though at Espengan. So please make use of the three one-pagers we have outside, which all the summary. You have also a booklet in terms of the clinical case studies and a little bit more in-depth information. So make use of that. There's also websites information on that. So something which you can really take home. We will have a panel discussion after the two presentations. So we will bundle all the questions after the two presentations. I will try to bundle them to the speakers coming from you in maybe what we were thinking, okay, one is about safety, one is about what is really the clinical evidence and so on. But the more important is, I think, and that is, I hopeful that you pull and push the speakers. What do you really think? What is your belief? What is your daily practice? Because evidence and data is another thing. Doing things is like the craftsman, something different. So, without further ado, it's for me a great pleasure to introduce Hanya Savieska. So, if we would go through her CV, we can actually stay until 8 o'clock. That is not what we want. But I only want to make two remarks about her CV. You can read it also. Most influential top 2% science and publicator. You don't get that just simply because you are publishing. You are getting that because people want to hear your opinion. And that also results in a lot of assignments. So, editor-in-chief of the ESPGHAN or the GPGN, member of the council, general secretary of ESPGHAN, and especially also secretary of the ESPGHAN Committee of Nutrition. And I think we will hear a lot about your other function, which is being the board of directors of the International Scientific Association of Prebiotics and Probiotics. And this organization has almost defined the field of biotics, and it is international accepted definition. So we will hear in the introduction from Hanya about pro, pre, and symbiotics for infants in food allergy. So thank you very much, and this is your floor.
I think, okay, now it's okay. Thanks a lot. Thank you very much. It's really a pleasure to be with you, with some of you again, because I met some of you. Well, I would say all invitations are equal, but some invitations are more equal than others. And all locations are equal, but some locations are more equal than others. So I really appreciate for being here. And indeed, I was asked to talk about probiotics, prebiotics, and symbiotics for infants with food allergy. And you kindly introduced me already, so I will not say anything about the scientific societies, which are very close to my scientific heart. And here are my disclosures. Food allergy and probiotics, prebiotics, symbiotics, is there a link? And of course, everyone knows that there is a link through microbiota. As one of our Belgian colleagues, but there's no one from Belgium, no. Am I right? Mm-mm. Anyway, one of our Belgian colleagues said, you are not human, you are a walking bacterial colony. And as a matter of fact, we are a walking microbial colony, because as we heard this morning, it's not only bacteria, but other microorganisms, including viruses, nicely covered in today's early presentation. And we know that the microbes are not just passengers. We know that they do have a lot of function. They contribute to immune function, to tolerance, to defense, to digestion, absorption, and what I really like, these crosstalks through all the molecules that they they produce some of the molecules like serotonin, for example, and they can have an impact on our mood. So I hope all of you have really hardly working bacteria and put you in a very good mood. I already saw this slide early in the morning that there are many factors influencing neonatal colonization, which are important, because if things go wrong, it can contribute to dysbiosis and allergy diseases, which is a topic of our discussion today. And I would like to go back to antibiotics, because I really think there's something that we can do, that we can reduce the use of antibiotics, but sometimes It's not possible, but really every now and then it is. Look at this data which I showed this afternoon also. United States, 70% of children below 2 years of age, they receive antibiotics. It's absolutely, I was reading it again and again. Data from New Zealand, they are saying 90% of children below 4 years of age, they receive antibiotics. Even data from Denmark, which is a country that you would say it's a country that there's hardly any unnecessary use of antibiotics, but there's also many children with respiratory tract infection, which a majority of them are viral, they are receiving antibiotics. And look at the consequences. There is, of course, it might be not for all statistically significant, but for most of the conditions, there's a significant increase. We are talking about associations. We are not talking about causation. We don't have such data, but it's really important for us. And another, which I not discuss this afternoon, but infants born by C-section. And we have data from large birds cohort studies showing that it has an impact on our microbiota, on Bacteroides, on bifidobacteria, which reduce, Clostridia, which are increased, gram-negative pathogens, gram-positive, which are increased. And I am afraid it's not very well presented here, but anyway, what I did want to show is a summary of many data, which shows you that, again, it's associated with a number of diseases, including allergic diseases. So C-section, in some of the countries, there are some people from Latin America, and correct me if I'm wrong, but the data from Brazil are saying in private settings, it's more than 80%. In my own country, Poland, it's 43%. So really the rates, and WHO recommends 10 to 15%. In many countries, I'm saying the truth, believe me. WHO says it should not be more than 10 to 15%, but in most of the rates are increasing. Every now and then it's a medical necessity. I'm not saying it's always unnecessary, but very often it is really not necessary. Gut microbiota and allergic diseases, this is a nice, I like evidence-based medicine, I like systematic reviews, and this is one of the recently published some time ago, which identified 21 studies looking at gut microbiota and allergic diseases. I will not read all of these because you can go to the paper, but what I would like to say is that most of these studies showing, first of all, there are differences. Usually it's reduced diversity. It's always better to be rich and healthy than poor and sick, and it's applied also to the microbiota, that it's always better to have a diverse, rich microbiota, even if we don't know what is a healthy microbiota. There is a lot of discussion about it. But anyway, there are many studies showing that there are links. The problem with the interpretation is that people are using very different methodologies. There's no standardization and it's for someone who is not doing this research like myself to understand all these differences. It's really not very easy to follow. So, but we know there are differences. And another study which shows also a microbiota alteration in infants associated with allergic diseases. So we know there are differences. We would like to have like a microbiome signature, like a characteristic pattern of microorganisms that would tell us, first of all, that it would predict the disease, that it would predict the response to the treatment, that we would say it will help us to make a diagnosis, not for allergy, but also many other diseases. We are not there as yet, but many people are working really on it. A lot of questions about what is the mechanism of this dysregulation of microbiome immunity, interaction, and disease. And we know that environmental factors, and I already mentioned some of them, are important. Genetics is important. It's really important to choose wisely your parents. Unfortunately, there is nothing we can do, but choose wisely, choose wisely. And of course, both contribute to microbiome disturbance. Again, reduce microbial richness, reduce diversity. It really is something that you can find in many of the studies. It contributes to immune dysregulation and through diseases, including allergy. But one of the important questions is which came first, the chicken or the egg? It remains to be determined if the alterations are a cause or the consequence. We know they are, But there are some studies like this one. It's probably one of the first studies, one of very few studies that show that infants' first stool predicts the risk of developing allergies. So it's very likely that first you have these microbiota changes and then it results in allergies. So in summary, for this part of my presentation, the gut microbiota matters, and there is an association of dysbiosis and pathogenesis of allergy, including food allergy. But the patient doesn't care about our science. What she wants to know is, can we cure him? Can we cure her? Can we prevent diseases? And this brings me to the next part of my presentation, which is strategies to modulate the gut microbiota. And you know there are many, biotics including, but also diet. Diet is a tremendously strong influencer of the gut microbiota. Fecal microbiota transfer. I will briefly talk about it later on in my presentation, but it's really amazing what you can do with fecal microbiota transfer, at least for recurrent Clostridioides difficile diarrhea. But let me go back to food allergy, and I would like to focus a little bit on EACI guidelines. EACI stands for European Academy for Allergy and Clinical Immunology, and these are the guidelines which were, the first author is Susan Halken, and I had the privilege to contribute to these guidelines on preventing and the development of food allergy, IgE-mediated food allergy. Various of nutritional interventions are covered in these guidelines. I am not going to cover all of them. I will only show you what is with regard to probiotics. I don't want you to read, but maybe yes, maybe you should try. I don't want you to read all these small letters, but overall, the evidence is very limited. If you look at probiotics, prebiotics, symbiotics, for the prevention of IgE-mediated food allergy, this is all that met inclusion criteria. There's a systematic review which accompanies those guidelines, so you can go and you can find the details. So what is the recommendation based on this very limited evidence for pregnant women and or breastfeeding women and or infants for probiotics, prebiotics, and symbiotics? There is no recommendation for or against. And Udo asked, what does it mean? I mean, in real life, no recommendation for or against. And it's clearly stated also in the paper that there is not sufficient evidence or the group was not confident to make a recommendation based on mixed evidence and experiences. For practices, it means that different choices will be appropriate for different people and that clinicians could help or should help each person make decisions consistent with their preferences. That one has to discuss what are the pro and what are the contra with a particular product we consider, because there are many products available, many food supplements. For some of them, there is some evidence, but there's even single trial, as you saw. But then one has to evaluate. For policies may differ depending on context and should be developed with the involvement of a wide range of stakeholders. It's a very guideline language, you know. It tells nothing and tells everything, I would say. Okay, but this is what is in the document. So practical advice, I would say, for probiotics, prebiotics, symbiotics, it's one of the options to be discussed. There's no recommendation for or against. And each probiotic, and of course this audience know, each one of them, probiotic, prebiotic, symbiotic, has to be evaluated separately. I would also like to talk a little bit about the management of food allergy, and there are various groups working on it. And one is a Galen, probably the most advanced because it's already after the public consultation and it is already submitted for publication. And there are other two groups, DRACMA is working. I think we are already working. I had the privilege to contribute to 3 of those. So I know how some of them went quite quickly. Some of them go very, very, very slowly for various reasons. So DRACMA, I'm saying pending, hopefully. And Espegan, Ivan van den Plas, I hope he will finalize, he's the first author that he will finalize. And it's interesting, you know, because you look at the same evidence within different group of experts, and it's amazing how different groups of experts are based on the same evidence, they are making different conclusions. It's very disturbing, very frustrating for the audience, for the clinical practitioners, like the question which was asked by Michael Lenze this morning. So one recommendation is different. So what shall I do? What shall I do if the recommendations, this is a whole topic for the topic for the whole discussion. So I will show you what is with these Galen guidelines. After public consultation, CMA, cow's milk allergy, we suggest that infants with cow's milk allergy who need a breast milk alternative use either hypoallergenic extensively hydrolyzed cow's milk formula or an amino acid-based formula. You are not surprised by this because this is exactly what is practiced, and it's difficult to look or interpret the evidence differently. We are talking today about probiotics, prebiotics, symbiotics. So again, no recommendation for or against for any of those that have been evaluated so far for managing food allergies. It's really important. So it's not for others, but those which were evaluated so far. What does it mean? I will not repeat it again. I will just call your attention that it's very much on us to discuss pro and contra various preparations which are available on the market. And I will show you some of the evidence. So I will start with probiotics, and we evaluated probiotics as food supplements and probiotics and other biotics as well in infant formula. And I will start with probiotics as supplement. 5 randomized controlled trials, slightly more than 400 participants, each about a different probiotic strain, you will see in a moment, or combination of strains in people of different ages with various food allergies. 2 trials found that probiotic supplements were associated with a slight reduction in food allergy symptoms, and 3 did not. And here's a summary, and you can see it's an evening, it's dinner waiting for you. I will not go into too many details, but look, these are all randomized controlled trials, mostly in Europe. And number of children, it ranges from 13 to 230, and very different combinations of probiotics. So now you understand that it's not easy, if you squeeze the evidence, that it's not so easy to make other recommendations than what you have seen in the moment. For prebiotics or symbiotics as food supplements, there were no trials meeting eligibility criteria. And this was for food supplements. Now I go to formulas supplemented with probiotics and prebiotics, symbiotics. Start with probiotics. Extensively hydrolyzed casein formula, 1 trial and 2 non-randomized comparisons of adding LGG to extensively hydrolyzed casein formula found a small reduction in symptoms and suggested faster development of tolerance. For extensively hydrolyzed whey formula, there are 3 trials of extensively hydrolyzed whey formula found that various probiotics were not associated with reduced symptoms. Every now and then in those trials you can see the difference between baseline and later on, but there were no comparison between the groups, or if they were, there was no difference. So it's important for the interpretation. And finally, extensively hydrolyzed whey versus extensively hydrolyzed casein formula, 2 trials comparing those, and there was no difference was found, did not improve symptoms or tolerance. This was for probiotics. For prebiotics, there were no trials meeting eligibility criteria, and for formulas supplemented with symbiotics, there was 1 trial of amino acid-based formula found that adding symbiotics did not improve symptoms. There were no negative impact on growth. And having said this, please remember I showed you what is a surge date. I did not comment on it, but there is certain surge date on the literature, and that's why the next speaker will cover new data. Dr. Rebecca Stratton will cover the new data on the role of symbiotics in evidence-based management of cow's milk allergy. When you read guidelines, it's always important to see what is the deadline, what was the search terms, but also the search date. This is a summary, again, of formula supplemented with biotics. I will not go into the details because I showed you the summary. but I hope it's clear that it was difficult to formulate other recommendations than the one which I presented you. There were some other considerations, like patients' career values. There is limited evidence about patients and career preferences, and these preferences are likely to vary between individuals. It's very likely with the real-world data, we will have much more about it. But at the moment, we did not have it. For feasibility and cost issues, there may be access and cost issues which preclude recommending these interventions routinely. And finally, for other consideration, we noted that there is a variety of biotics, and many have not been evaluated so far in clinical trials. And once again, not all biotics are the same, and each needs to be evaluated separately. So, where are we now? I showed you the evidence. So where are we now? I think all of us would love to see something like that at the end of the manuscript. We believe this resolves all remaining questions on this topic, and no further research is needed. Well, we are not there yet, as you know. There are many gaps in the evidence for managing food allergy, effects of supplementation with different prebiotics, symbiotics, high quality, as always, I mean, more studies are needed. Everyone is frustrated with that. But what is the future? What is the future? And I would like to very briefly comment on the publication, which was co-authored by some of my colleagues from ISAP, International Scientific Association for Probiotics and Prebiotics. And as you can see, there are many variants of microbiome modulating interventions which are being developed. And let me very briefly comment. For probiotics, definitely there is a lot of discussion about next generation probiotics. So these are probiotics from genera with no history of use as probiotics and which are likely to be delivered under drug regulatory framework. Akkermansia muciniphila, EFSA now accepted it as a postbiotic, but it's definitely one of those bacteria which is of huge interest, and I am sure we will hear much more, so we will see, but there are also other candidates. For prebiotics, currently there is a narrow range of confirmed prebiotic substances which are being studied and used, so novel substrates are of interest to stimulate a wider group of commensal organisms, hopefully only the beneficial one, not other ones, and novel delivery technology to deliver for delivery of intact prebiotics towards the distal colon and selective stimulation. So as you can see, there are some concepts what can be done in the future. For other biotics, we already discussed in the afternoon postbiotics, inanimate microorganisms and other components. I already, with my Polish colleague Jarek Kwiecień, who is sitting here, we were discussing how to translate it into Polish in a better way that I have done it by now, and he has a very good suggestion. Other considerations relate to microbial consortia. It's defined as a mixture of microbial species with symbiotic interactions. It can include well-defined consortia with fully characterized members or undefined mixtures. And allow me to comment here. I already mentioned at the beginning the fecal microbiota transfer, which is probably one of the most successful strategies to manipulate gut microbiota, which we studied or observing in the last, let's say, 10 or 15 years or something like that. If someone 15 years ago would tell me that we would treat people with the poop, with the stool, I would say, Wakama, you are crazy. But we know now that the FMT is, in all of the guidelines on the management of Clostridioides difficile diarrhea recurrent, this is a standard, I would say, treatment. And it really makes me think that in the future, we will be not discussing about single strain or single prebiotic. We will be talking about, as it's here, microbial consortia. What it will be inside, I have no idea. I would be rich if I knew it. But I really think this is a direction to go. And personalized biotics, it sounds very well. An individual's gut microbiota composition might be used in predicting responses to biotic intervention. Sounds fantastic. but I think we are far away from that. I always think that it would be bad, really nice, but I don't think we are here. So, probiotics, prebiotics, and symbiotics in infants with food allergy. You may ask yourself, bright future or waste of money? And be careful with what you predict. Be very careful. There is no reason anyone would want a computer in their home. We don't like their sound, and guitar music is on the way out. Decca Recording Company rejecting the Beatles in 1962. And last but not least, my favorite, there is no chance that iPhone is going to get any significant market share. No chance. And with this, I thank you very much for your attention.
So the last slide is really an eye-opener. Thanks a lot. And I was actually intended to comment. We have a lot of expectation. Everything has to go fast. The iPhone is now, how old? 70 years or whatever. Yeah, 17, yeah, so 2003 or something like that. But if you look into the launch of Biotics, that was in 2000. We are now 2 decades, more or less of 2 decades. And look what we have all achieved. Look about how many probiotics, prebiotics are available and how many are on the market. And obviously, it's a personalized decision. And why I wanted to comment, in my introduction, I'm also the president of the Industry Federation of Specialized Nutrition, and we are in very close contact with the policymaker. And the biggest problem, I think, what is also in the guidelines, in the development of the guidelines, once you make a recommendation for whatever it is, the policymaker needs to make it mandatory for everybody. So there's a huge responsibility. So yeah, why you cannot make evidence on 2 studies or whatever. Actually, we are talking here about, in the European Union, about 500 million people. You are better thinking twice on also the economical implications and so on before you say this is the strain and this is the population we want to make it available. So it's a great pleasure for me to introduce my colleague Rebecca. She's from UK. She's working in coming originally from Southampton. She's from training a scientist and a dietitian. But more important, she is really a researcher, a study designer, a study executor, and working on an extensive number of clinical trials, not only in cosmic allergy, but also in other disease-related, malnutrition-related diseases, not only in infants, but also in adults. And she has over 250 publications. And she's a little bit like Hanya, this interaction with clinicians and societies and so on. She is the faculty member of ASPEN, which is the European Society of Clinical Nutrition and Metabolism, and she chairs there the Malnutrition Action Group of the British Association. So really also the patient contact and so on. Therefore, it's for me a great pleasure to welcome Rebecca on the role of symbiotics in evidence-based management for cosmic allergy. Thanks a lot.
Thank you, Udo. Sort of hoping the slides are just going to appear. Perfect. Okay, well, it's amazing to be here in this beautiful setting. I know I'm keeping you from dinner and wine, and you've had a long day already, so I hope you can stay with me for the talk. And also to say it's a real pleasure to come and talk on the topic of allergy. I am an adult dietitian by background. My real passion for allergy came when my daughter actually was diagnosed with a very severe form of cow's milk allergy, and I really developed an interest and a passion in wanting to understand more about how we can manage that condition. So here is a mum as well as a dietitian. So here we go. So One of the things we've been very interested in is to understand what is the impact of cow's milk allergy in the longer term. And it's something, again, you're quite passionate about when you've been through and experienced that as a parent. So we have just recently published some data that you will see here with some co-authors, including Roseanne, who you've heard a few times today and yesterday, and Kate Grimshaw, looking at a retrospective matched cohort study. So these are real live, real world evidence, so GP records that we're very lucky to have in the UK, which actually are looking at what's happening in practice to infants with cow's milk allergy or many other conditions. And in the UK, we have this very special database called Clin, the Health Improvement Network database, with around 2.9 million records from 365 general practices. So it's a very special database which allows us to really look at trends and treatment and look over long periods of time. So the observation time was 4 years, and the mean age of diagnosis of this cohort with cow's milk allergy was 4 months. And what we were interested in was to see, well, what is the course for these infants over time, beyond that time when maybe if you're an allergy clinician, you're monitoring them. We looked at symptoms, infections, medication prescriptions, and healthcare contacts. And what you can see here, firstly, is very sadly, significantly more children with cow's milk allergy go on to have gastrointestinal, skin and respiratory symptoms. And you can see this here with the proportions of the CMA cohort and the non-CMA cohort. You can also see the rate here per 5 person years, significantly higher in all cases. But we also found in this data that the symptoms persisted for significantly longer among those with cow's milk allergy than those without. You may be familiar with that in your clinical practice, I don't know, but it was very interesting to see it in such a large cohort. But one of the things we were particularly interested in was what was happening with infections, because anecdotally, many people have said, oh yeah, I think children with cow's milk allergy, they go on to have more infections. So we want to say, well, actually, let's see what the data shows us in the UK, this is. And we found that these children, this cohort of children, had significantly more infections. So you can see here again, gastrointestinal infections, skin infections, respiratory infections, and ear infections. Again, you can see the proportion of children affected in these two cohorts and the outcome rate per 5 person years. So highly significant. It's an interesting finding. But we're also looking at healthcare use. So the clinical consequences have been published, but this data has also been submitted for publication. And what we found is that children with cow's milk allergy have significantly greater healthcare use than children without cow's milk allergy. And again, this may not be a surprise, but it's interesting to see when you look at the medication use. You can see here, across the two cohorts, all significantly different. And of course, there is a cost implication of this, not only for society, but also for those children. We also have looked at the use of healthcare resources. So I don't know about your health economy, but our health economy in the UK is extremely cost-focused. It's all about saving time, resources, money. So it's interesting again to see that these children have significantly greater GP, dietitian, hospital specialist consultations, and significantly more hospital admissions. And what we've been able to do is a very simple economic analysis, very simple. And in honor of being in Denmark, I did put Danish crowns. For those of you who are European, euro, and of course for us Brits who like to be different, the pounds. But you will see here the estimated healthcare cost is significantly different between these two cohorts. And again, it may not be a surprise, but very interesting and useful to be able to demonstrate that. Of course, then we want to know, well, what can we do about that? So, of course, we can see a longer-term burden in these infants and children with cow's milk allergy. What is the reason for this? And of course, we're working from GP databases, so again, you don't have all the information, it's retrospective. Of course, I'm a dietitian. I think, well, actually, what are the implications for nutritional management for these individuals? Is there an implication? Of course, breastfeeding is the best option, of course. When breastfeeding is not possible, what are the options? One of the hypotheses around why there might be this longer-term burden is the gut dysbiosis that we've heard so much about already this evening and during this conference, everywhere actually. And we know it's prevalent among infants with cow's milk allergy. Does this influence the inflammatory and the immune response, the gut-brain axis? What is it that then leads to clinical consequences and this poor outcome? And if that is the hypothesis, then you would imagine that if you do something to change that, you may change the outcome. And that is the question. So that is something we've been interested in looking at. So my life has been spent in other areas of nutrition looking at the evidence, doing systematic reviews and meta-analyses, lots of different areas. So I thought I would turn my hand to the field of cow's milk allergy. This is work that was published in Nutrients in 2021. So you will find that actually that probably hasn't been included in a number of the guideline reviews, although I don't know that for sure because they are pending. So this is a systematic review and meta-analysis of randomized controlled trials that compare a hypoallergenic formula with symbiotics versus ones without symbiotics. In our inclusion criteria, we included extensively hydrolyzed and amino acid formulations. We included infants and studies in infants and children with cow's milk allergy, not other allergic conditions, with IgE or non-IgE. Followed the PRISMA guidelines, and again we had an inclusion period as well of time up to November 2020. So we found 7 publications and 4 randomized controlled trials. You can see here the data, and again for those of you who like delving into the detail, take a look at the paper because we haven't got time to go into all of it, but you will see here around 410 included. All randomized controlled trials compared an amino acid formula with symbiotics. You can see there the detail given for a mean of 7 months. They were all compared with an amino acid formula with no symbiotics. At the time of the review, there were no randomized controlled trials comparing an EHF with a symbiotic compared to no symbiotic in cow's milk allergy. Using the Cochrane risk of bias tool, most publications were at low risk of bias. So what did we find? Actually, the first very interesting thing when you put the data together, and again, this is a synthesis of randomized controlled trials. You can see here a highly significant result. So significantly fewer infections here when you put together the data from 3 randomized controlled trials. Here is the group, the patient group. Here is the duration of intervention. Okay, so they're a mixed group, interventions from 8 weeks to 12 months of amino acid with symbiotic compared with an amino acid formula without, with various infections including ear infections. This is a synthesis of data, and in each one of these randomized controlled trials, infections were not a primary outcome. So again, you could argue, to Hanya's point, we need more evidence, we could look for primary outcomes, but this is the synthesis of randomized controlled trial and meta-analysis of those. We also explored what had been synthesized in medication use. So this, again, is an exploratory outcome in 2 of the randomized controlled trials. You're probably familiar with them. And we could see, and again, it's quite difficult because to Hanya's point, different authors and different studies synthesize information in different ways, look at it in different ways. So it makes our job quite difficult. But you can see here a reduced antibiotic medication use, quite markedly, from the synthesis of 2 randomized controlled trials. But in individual trials, they found significant reductions in the use of functional GI, emollient protective or dermatological medications. So interesting. And then we again looked at hospital admissions. So it's a very important outcome in the UK for our health economy, for our health system, also for patients because you don't want to be going into hospital. We could only find 1 randomized controlled trial here, which you can see on the right, which showed a significantly lower rate of hospital admissions in those receiving the hypoallergenic formula with symbiotics. This was a serious adverse event data set on hospital admission for a GI infection. So again, not a primary outcome, but very interesting nevertheless. And we can never resist actually doing a simple economic analysis. And actually, when we look at health economic analyses, our payers actually don't always want the most sophisticated analyses. So what you can see here is the mean cost saving per infant per year based on our NHS costs. We have lots of reference costs for use of healthcare, so for example, hospital admissions, and of course the costs of the amount and duration of formula. You can see here again, ranges from £164 to £338. Again, you can see the euro and Danish crown values. So you can see much more information about that in the publication of Nutrients. What is the reason for those improved outcomes? What do the findings of the systematic review show us? So, symptoms. The systematic review, when you look at the data on symptoms, each formulation equally effective when you look at the trials in the review. Okay, so symptoms, they are as equally effective as each other. The studies have looked at growth. So in the meta-analysis, you've got 2 randomized controlled trials of 3 papers that found that actually the hypoallergenic formula with symbiotics in the studies included was equally effective as one without symbiotics, supporting growth in line with expectations. So weight, height, length, and head circumference at 8 and 16 weeks. It may not surprise you that what I'm going to show you is where we did see the differences when you synthesize the evidence, which interestingly used consistent methodology for the assessment of fecal microbiota, was gut microbiota. So the meta-analysis of 3 papers found that the hypoallergenic formula with symbiotics versus one without led to significantly greater fecal bifidobacterium species and significantly lower fecal Eubacterium rectali and Clostridium coccoides species. This was at follow-up at 8 and 26 weeks. These were primary outcomes, and was also found to be significant at earlier time points of follow-up. So, interesting. But coming back to what happens in real life, also really interested to see, well, what has been happening in clinical practice in the UK. So in the UK, we have had hypoallergenic formulations with symbiotics on the market, available for use clinically for quite some time now. So it gives us a unique opportunity to look at what general practitioners are doing. So actually what you can do is find those infants with cow's milk allergy that are on that type of formulation and compare them with those that are not. So that is what we did. Using Clin, which is the same database I spoke about earlier, what we did, we've got a nice fly that's hovering around as well. We looked at 148 infants with cow's milk allergy that were prescribed an amino acid formula with symbiotics or matched with an amino acid formula with no symbiotics. So again, this is retrospective, matched cohort study. We looked at outcomes, symptoms, infections, medication prescriptions, and healthcare contacts measured from diagnosis. This is data that is also published in Nutrients. This is a different paper, okay, published later in the year. We had a busy year last year. What did we find? If we look here, this is looking at the all-cause outcomes from symptoms, infections, medication prescriptions, healthcare contacts. And what you can see here in this matched cohort, again, remember it is retrospective, but we see some nice differences. You see significantly, and this is outcome rate per person year, significantly lower symptoms, all cause, but symptoms, infections, medication prescriptions, a lower healthcare contact rate, but not significant. These were measured from diagnosis for just over 1 year period in this database. What we also looked at, brace yourselves, this is not a graph for this time of the evening, so I'll be brief, but essentially, Denizio, very, very talented statistician, has done some regression modeling. Yeah, so what you see here is a proportional hazards regression model that is looking at what we call a composite outcome of 3 months of being symptom-free and not needing the hypoallergenic formula. And you can see on the right-hand side the probability curve for those who have an amino acid formula with no symbiotic compared to those with an amino acid formula with a symbiotic. What we find is, compared to the amino acid formula without symbiotic, infants who are fed an amino acid formula with symbiotics have a significantly higher probability of achieving asymptomatic management without a hypoallergenic formula. So it's looking at the probability of this composite outcome. And a shorter median time, which you can see very beautifully here, to achieving that symptom-free management without a formula. And with that, you can calculate a potential cost saving of that 31% shortening of time of around £452, around €500. Why do we see those differences? Are the outcomes attributable to the effect of the symbiotics on the infant gut microbiome? Well, we have a beautiful healthcare system in the UK, but we don't look at microbiome in clinical practice and certainly wouldn't be in a GP's record, so we don't know. And remember, this is retrospective matched cohort, but very interesting to give us a little bit of extra confidence in combination with the randomized controlled trials and the systematic review. So I'm nearly finished. In the UK, we have predominantly had an amino acid formula containing with symbiotic on the market. How very recently we have had an extensively hydrolyzed formula come onto the market with symbiotics. And of course, you would want to start with an EHF as opposed to an AAF formulation. This is not a randomized controlled trial. This is a longitudinal, so it's one group followed over time, and they are their own reference group. Again, it's just the reason for showing it is very, very recently published, just last month in Immunity, Inflammation and Disease, with a big team of dietitians who work across the UK clinically, who actually have recruited around 29 infants with non-IgE cow's milk allergy on an extensively hydrolyzed formula with the following short chain GOS, long chain FOS, and Bifidobacterium breve M16V, so versus a baseline on EHF. And what we found over time, and again, they are their own control, this is a cohort already pretty well managed on an EHF. What is the difference? What were the differences we found? We found incidence and severity of abdominal pain, flatulence, burping, and constipation significantly improved. You can see that over here. And in those with the most severe atopic dermatitis scores at baseline, remembering pretty much this was already quite a well-controlled group, so only in those with the most severe AD did we see a difference. Again, these are small numbers, okay? This is small numbers. But what we're very interested in as well is how do patients or caregivers feel? What is their response to management? And we looked at caregivers who reported significant improvements in quality of life over the time. We've also looked again at the pre and post period of healthcare use, so the 6 months before and after the use of the symbiotic containing extensively hydrolyzed formula. You can see here some nice differences in overall hospital visits are significant, and also you can see here overall medication prescriptions are significant. So again, a little bit of confidence. It's not the perfect evidence, it's not the perfect design, it's about a combination of different sources of evidence and in clinical practice that help us to think, yeah, actually I'm getting a feel here for something. What we are also working on, and again I hear the discussion around where are stakeholder views, where are patient-parent views. So we have done some research looking at sort of more informal surveys, not just of healthcare professionals, but of parents who are looking after their infant or their child with cow's milk allergy. And how do they feel? What do they perceive? And they themselves report, it's not a randomized trial, it's their perception, reduction in infections, fewer visits, and also improvements in quality of life. So we will present this data later this year at EARCI. So, in summary, I hope that you see that the new evidence that we've looked at suggests, at least from the UK in the cohort, that there is a longer term clinical and healthcare burden for the infant and child with cow's milk allergy. Of course, gut dysbiosis in infants with cow's milk allergy may be a contributory factor because the infant gut microbiome is so important, not just in this area, but in so many areas. Breastfeeding remains the best option for feeding. But of course, if the formula is required, we see that use of a hypoallergenic formula containing symbiotics appears to be associated with significantly fewer infections, prescriptions, and healthcare use compared to a formula without symbiotics. When we look together with real-world GP data, that suggests a higher probability and a shorter time to achieving symptom-free management without use of a hypoallergenic formula, with the use of symbiotics in the formula. There may also be benefits of quality of life, and that is very important. These outcomes may be related to the effect of the symbiotic on the gut microbiome, bringing it closer to that of a breastfed infant. But I'm going to say more research is required as ever, so that we really understand the mechanism, but also to assess in a very well-controlled manner the longer-term impact of modulating that infant gut microbiome and the impact on outcomes in the management of cow's milk allergy. And my last slide is really just to show you the picture of my beautiful daughter at Southampton General when she had her assessment, when she was having her challenge for FPIES. And I just want to say firstly, thank you to everybody who works in the field of allergy, because when you become a parent, you appreciate it in a very different way. But I also wanted to say we still have a role to play to improve the awareness of how to diagnose, when the right time is to diagnose, and how to effectively manage it. And many of you here are advocates, you are interested, you know it all, I expect. It's the people that never come here, it's the general clinicians who don't understand allergy that would be really good that we can be the advocates to improve the management so that people like my daughter will have a smoother ride in the short and the long term. Lastly, just to say thank you to my research team, my collaborators, so Roseanne, Lisa Cook, Glenn Gibson, Kate Grimshaw, funding received from Nutricia, and just here as a summary of the relevant publications. Thank you very much.
Thanks a lot. Fantastic. So, unbelievable, we are right on time. Please take a seat. So, as I said, let's spend 8-10 minutes on topics. Every question from the audience is obviously welcomed and appreciated, so I encourage you. At the moment, I feel I need to kick off, but be active, yeah? This is your session,
Great.
your panel discussion.
Have our dinner.
And so I like to kick it out on the safety. Safety, we have a legislative process and so on, so the approval of the probiotics is no question about that, so in terms of safety. But is there any condition you would say to Hanya, where you do not recommend the use of probiotics and symbiotics? The background I'm asking that is, let's go to the very, very severe cases. Let's go to those infants who are dropping out of the percentile, yeah? You need catch-up growth, who have a disturbance at the gut microbiota. Is there any condition you would say, okay, no?
When we are discussing safety as a group, we are always discussing premature infants. And let me comment on this, because it may be applicable to other populations, that for preterm infants, where there is an issue of safety, for example, in ESPGHAN guidelines, what we said is that the probiotic product, which is supposed to be used, we need a guarantee from the manufacturer that it's a manufacturer according to the highest standard. For example, in many European countries, you cannot have I don't know how it is in UK, but for example, in our country, something which is registered as a food supplement, it cannot be delivered to patients in the hospital. So this is an issue because very few are registered as drugs. Of course, it's a different issue when you have it added to infant formula. But you ask me in general. So I would say this is an example of a vulnerable population which precautions are needed. And if you use it in such a vulnerable population, you manage to solve it with your pharmacy, with your hospital, etc. I think it's important that the laboratory knows, your microbiology knows, which kind of microorganisms you are using, and they are prepared that in case of septicemia, in case of bacteremia, they can also test it for this particular microorganism. And this is clearly stated in ESPGHAN document on the use of probiotic for preterm infants. And I think that the same approach may be applicable to all these other vulnerable populations.
So, as Nick, please.
Yeah, I guess from the UK perspective, the symbiotic containing formulations, our authorities had suggested some contraindications. So the immunocompromised patients, short bowel syndrome, and post-jejunal tube feeding immunocompromised patients. And they also had some restriction on those with central venous catheters, bizarrely. So, yeah.
But you're speaking about infant formula supplement.
I'm talking about, yes, not food supplement. That's UK specific.
Thank you for your outstanding presentations. And my question is, what I am concerned is about undernourished children. And we know that we have a reduction not only in richness, but also in diversity. And what happens when we have children with undernourished and we have chemical allergy, because we have a leaky gut, we have a different microbiota, and what is the real impact of the use of symbiotics, what the real impact of the use of probiotics, special strains of probiotics in this special group of children?
Well, I did not follow recently the literature on undernourished population, but there are some studies, and I think they were even performed here with a Dutch group with children with malnutrition. I doubt now, I just don't remember the results. I think they were safe, that there were no reported adverse events. I don't remember what was the primary outcome of the study. Perhaps we can communicate and I can find that study. But definitely this is one of these vulnerable populations. There are not so many studies, and I'm not aware of the study in cow's milk allergy with undernourished. So without evidence, all you can say, it's well, you have to really balance potential risk and benefits.
I say because we are from Argentina, and Dr. Pochamer said from Argentina, and we have this kind of group, and I think that it's
but I don't think that we have at the position at the moment to say it's safe. On the contrary, I will repeat again, it's really one of these very vulnerable populations which will have to outweigh the potential benefits and risks. And also the quality of the probiotic product, it's extremely important. I mean that because we know that there are issues with and also in your part of the world there are reports.
To add, from a responsibility of the manufacturers, that is the bread and butter. You could kill more than your business. Please. Then I would move after your question to evidence.
Thank you. Rokar from Slovenia. I don't know if you can answer me, but we have now two formulas. One is extensive hydrolysate with Biotics, and another one is amino acid formula. I know you haven't done a study comparing the two of them yet. But I'm very interested, although I hypothesize that if we have another big group, then there will be a little bit in favor of efficacy on a short level for amino acid formula, because they will cover also these 3% of children who need a little more than extensive hydrolysate. But what about on long term? For me, it's very interesting that the children on symbiotic formula, let's say, outgrow their allergy faster than children are on normal amino acid or hydrolysate formula. What do you think? Because we know that we need a little bit touch of these antigens also for development of tolerance. What will happen about this outgrowing of allergy comparing these two? I know Hania will say there is no evidence to say anything,
Exactly.
but what do you...
You even said exactly the same at the beginning, that there is no evidence to answer the question. We can hypothesize, but it's not what we want. I mean, for formulation of the recommendation, you really need the evidence. And allow me just to comment on the evidence, that you look at the specific outcomes. It's not that any outcome will be considered. Like, for example, Rebecca mentioned many studies, including randomized controlled trials. They were not all of them included, and the reason is that the outcome of interest was not there. So this is the only reason why And unless you have such studies, there's no way we can answer. And my heart can be on one type of the formula or another, but it's not about the heart, it's about the evidence. Rebecca, you may have
I expected this answer, thanks.
Yeah, so we need some budding
We know each
researchers.
other for too many years, I would say.
But can I pick that up, and we are moving to talking about what is the relevance, the evidence, and so on. You know, I think the first hydrolysate for the dietary management of allergy is 1920 or something like that. So it's more than 100 years ago, yeah. And we are talking always about hyperallergenicity. And what is beyond hyperallergenicity? Where do we see here the evidence? That is actually, I think, the question about active management of cosmic allergy, managing the gut microbiota and all that. Are we there? Taking your last slide, no research needed, all questions answered, close the book? On the concept. On the concept.
Well, I'm a researcher really at heart, so I would always say there are questions. So on the outgrowth, to your point, you want that trial, you want the right level of evidence to show it. But what you don't want to do is just always be waiting. So you, as clinicians, you've got to do something, haven't you? You've got to go, yeah, we have to move. We can't always wait for the perfect evidence either. So there is a balance. So I think we've got some good strands, we've got some good hypotheses, but we still need some research to confirm those hypotheses.
That's why the recommendation says use for cow's milk allergy, for the management, you use extensively hydrolyzed formula.
But you know,
you would always say,
but
yes.
you know,
Or amino acids formula. I know that you would like to hear which particular.
No, not even that.
But then there's a decision each one of us.
But I don't let you off the hook on that, because you know you had shown this fantastic slide, yeah. Waste of money, or is it really? So if it is waste of money why? So is it waste of money?
Well, that might depend as well who you are. Are you the person who's choosing to give your budget? Are you the parent who says, actually, if I've got a hope that my child will get better quicker and won't go on to be sick for 6-10 years, boy, would I have chosen that if I had that option.
Mm-hmm.
Depends on your perspective. You're a clinician, you might go, no, I'm going to wait for the randomized controlled trials. Thank you very much.
Yeah, and also this is for the interpretation of guidelines, for
Yeah.
clinicians, for policymakers, for stakeholders. So I think this is really important for the interpretation of the guidelines. And again, no one is saying that extensively hydrolyzed formula or amino acid formula should not be used. On the contrary, this is the formulas which all of us use.
Yeah.
I would say I would put it the other way around. I mean, if it's the first was in 1920, as you say, and it's almost 100, probably 8 years of something, and we still have such a limited evidence, something is wrong.
Yeah, but that is the regulation, you know, 95% with confidence interval, and then it's done. Yeah. So therefore, we need this new concept. Sorry.
Thank you. So you very wisely say you need to discuss it with the families, the pros and the cons, and we have the potential cons that we hope that they will help for, and the potential costs on the other side. Can you elaborate a little bit more about the pros and potential cons to discuss with the families?
You are speaking, now we are talking about addition of probiotics, prebiotics, or symbiotics.
Yes.
Well, I would say, as Rebecca showed, I will answer on my part. For example, if there is reduction of infections, I will go back again to my favorite topic, which is a reduction in the use of antibiotics. I keep saying, if it's the only benefit of using infant formula supplemented with probiotics, prebiotics, symbiotics, or whatever, for me, it's already something worth considering, even if, when it comes to the acquisition of tolerance, there would be equal effect for both formulas. But if you reduce the risk of infections, if you really don't reduce the use of antibiotics, for me, even if it has nothing to do with outcomes such as acquisition of tolerance, I think it's, for me, worth considering. And this is something that you can use in the discussion with patients.
Yeah, I think similarly. If you're a mother and a parent, you know what you want to see for your child. So we always come at it from a healthcare lens, maybe rightly, wrongly. but what does the parent want for their child? And then if you know what that is, then you think, well, actually, does this meet their needs, for example? And when you're looking at the data that we have so far, if you can reduce infections, symptoms, we're also seeing this improvement in quality of life. That for me, that's really important, and we often forget that. Yeah.
But the cons.
The cons.
Yeah, also.
Well, I would say the cons are the costs, because for many families, extra costs. But then again, you can look at it from two sides, saying, okay, it costs more, but on the other hand, there is likelihood that you will reduce the risk of infection. So, I mean, you have to balance and
so
then
you choose, yeah.
I was just wondering if it's more than costs on the con side, or just the costs.
Well, but cost is already something, I would say, for me, especially nowadays when inflation goes up. I would say this is already something.
And I guess it depends where you live. So in some, like in the UK, it's fully reimbursed. So the family don't have to pay. Of course, the health economy, the healthcare system pays, but then the parent's not making that.
Cons is, of course, you may say, well, it's not so well documented that it has an impact on the acquisition of tolerance. So you have to, as a parent, as a clinician, you have to understand it. But again, there are other benefits which may be important.
Yeah.
So, last part, my favorite part, yeah? Yeah, looking behind the curtain, yeah? And looking a little bit, you have already said it, beyond the dietary management of cosmic allergy. So I will ask Rebecca, yeah? So you have always, when you start studies, you have a certain protocol, a certain outcome, a certain hypothesis behind, yeah? What drives you. But there's a moment, what has you surprised in those studies? What was really a kind of, aha, that I have not expected, a new insight?
Well, I think for me, I always love putting evidence together and showing that data. I think to see a reduction in infections, I thought that's really powerful for me. But the thing that most surprised me was the retrospective match cohort trial and the marked difference that we saw in those journeys. That sort of, yeah, the symptom-free part, that for me was unexpected.
Why?
Why was it unexpected?
Yeah.
Because you desperately hope to see it. And as a researcher, you start with a null hypothesis, there won't be a difference.
Yeah.
And then you see there is a difference,
Yeah.
and you think, actually, and also from not only my clinical perspective, but from a parent's perspective, you think, actually, if you can really make a difference, ultimately, what do you want to do is prevent it happening in the first place. So if you had to ask me what would be my wish, you want to stop anyone ever going through it, even if having the allergy.
Choose your parents wisely.
Yeah, I failed miserably for my daughter.
Sorry.
Yeah.
Can I?
Choice of your daughter, not of you.
Yes, not of me. Yeah.
Can I turn it around? Choose your HCP wisely? Is that? So this is connected to my question to you. What at the end of the day are you recommending in your clinic? Because you have the same. So if I come and say, I want the best of my daughter, I don't care what it costs or where it comes from. So what are you saying?
Come to me. I will give you a free advice. I will not charge you.
Okay. Yeah, but it is a different. So please, yeah.
I would like to ask Dr. Rebecca, how did you define infection in your retrospective study? Because sometimes there may be an overdiagnosis of infection in people with allergy that has diarrhea. How did you really know it was an infection?
Yeah, really good point. So from those, they are GP records. So what you're working with is recorded information by GPs. So they are specifically coded. So you know that they are specifically coded in that way, whether the GP made the right diagnosis. However, you would assume that if there is error in that recording, that it would be equivalent across the two groups. But it's a valid point. It is only as good as what the GP has recorded in the system.
And in this respect, the information data on the use of antibiotics are more reliable because, first of all, parents do remember, especially early in life, that they, and also it's clearly stated. So we may have doubts with regard to the definition of how the diagnosis of infection was made, which I really agree with you, but when it comes to the use of medications, the use of antibiotics, they are really reliable, in my opinion, these are reliable data.
Yeah.
Thank you.
Please, can you just hand it over?
Concerning the follow-up of your cow's milk allergy group and non-cow's milk allergy group, I was thinking of the dysbiosis of these cow's milk allergy kids. You didn't mention any case of IBD.
Of what, sorry?
Of IBD, inflammatory bowel disease, colitis or Crohn's. Maybe the time period is too short.
It's a really good point to look, actually.
Because
in terms of other-
dysbiosis, I have several cases actually,
Oh, okay.
where the parents with ulcerative colitis, where the parents told me in the beginning there was a cow's milk allergy.
Oh, we should look. We should look into the
Please,
data.
do so.
Yeah, thank you.
And maybe a second short question, maybe it's a long discussion. What is the role in allergy prevention of partially hydrolyzed formula?
Well,
I
if
mean,
you go to the document developed by the IARC, it's exactly the same recommendation. No recommendation for or against. There were a number of interventions and partially, or not only generally hydrolyzed formulas, including partially, were no recommendation for or against. But please remember, IARC guidelines are only looking at the outcome, IgE-mediated cow's milk allergy or food allergy. We did not look, the guidelines did not address any other outcomes. It's very important for the interpretation of those guidelines.
Okay, thank you.
Thanks a lot.
We are giving probiotics, prebiotics, the same to everybody. But if you look at the first published article 11 years ago regarding enterotypes, so maybe there is a clue why the results are so different between the studies. Not only that we are giving some kind of different kind of prebiotics or probiotics, but maybe we can the same do as with blood transfusion.
Well, but you know what will be my answer? If it's a randomized control trial with properly powered and well-done randomization, you should have this equally distributed, all these differences. I agree that there may be some differences, but it should be in a well-conducted and with a proper randomization, they should be equally distributed. So this should not be, there's a confounding factor. I mean, I would not, in a well-conducted randomized control trial with a proper randomization. But yes, of course, we don't know what is we even don't know what is health-associated microbiota. The differences may play a role. But I think that for randomized control trials, in a way, we are solving this problem.
Any further question? Oh yeah, please. Sorry. Thank you.
Excellent presentation. I can ask for you that is when we see the different study of allergy, we see a patient with allergy food with IgE and no IgE. And in the practical clinicals, we see different patients. Different tolerance, different several symptoms. The indication of this formula with symbiotics or amino acid or hydrolyzed is different in this different situation type of food allergy?
No, for both IgE and non-IgE mediated, you do have those two choices. Frankly speaking, amino acids formula as a first treatment is only for anaphylaxis. In all of the guidelines, the first choice is extensively hydrolyzed formula. Eosinophilic esophagitis, it's another indication that amino acids formula would be the first choice.
No, and some of the studies have combined both IgE and non-IgE, some are non-IgE and IgE. So you have evidence across both populations from what we've looked at. Yeah.
So, last question. to make it smoothly to the dinner.
Is dinner ready?
Yeah, is dinner ready?
We're
Yes.
hungry.
So we will have a dinner, a two-course dinner. I will look where we are. Then we will officially, when everybody is ready, officially close the meeting. My colleague will then also close it. And then I think we have even readiness for Copenhagen tonight. So thanks a lot.
Thank you very
Thank
much.
you.
Thank you. Thank you, Udo.